And welcome and good evening, everybody. I am Dr. Bill Tulo, Medical Director of OCULUS Inc. And welcome to the OCULUS Clinical Webinar Series. I'm really excited tonight to have a special speaker. Dr. George Waring IV is going to talk to us tonight about Pentacam AXL WAVE and the updated full sequence displays for screening refractive and cataract surgery patients. Before we get started, I introduce Dr. Waring. A little housekeeping for everybody. If you have questions tonight, please use the chat feature to enter your questions. We'll leave some time at the end to answer any questions that you have. And next, I'd like to introduce Dr. George Waring IV. He's the founder and medical director of Waring Vision Institute in Mount Pleasant, South Carolina. He also serves as adjunct assistant professor of bioengineering at the College of Engineering and Science at Clemson University. Dr. Waring has served as associate professor of ophthalmology and director of refractive surgery at Medical University of South Carolina Storm Eye Institute. He's a diplomate of the American Board of Ophthalmology and a fellow of the American College of Surgeons. Dr. Waring has received numerous awards and distinctions in ophthalmology, including the Presidential Award and the Distinguished Lands Award, both from the International Society of Refractive Surgery. He's active in clinical research and incorporates the latest technologies into his practice. He's performed surgery, taught new surgical procedures, and delivered invited lectures on 4 continents. He participates in and chairs of numerous professional committees and sits on the editorial board of both the Journal of Cataract and Refractive Surgery as well as the Journal of Refractive Surgery. Dr. Waring serves on the executive committee for the International Society of Refractive Surgery. And without further ado, Dr. George Waring, welcome.
Bill, thank you so much. And it's really my pleasure to be with you all tonight. And want to thank all of you from taking time away from your family and loved ones after a busy day at work for educational purposes. So we hope that you find this worthwhile. And this is an exciting time in cataract and refractive surgery. We've really never had the tools at our disposal to provide the best outcomes in history. That's extends to intraocular lens selections, lasers for both corneal and lens in cataract surgery, advanced technologies and diagnostics. And we're going to talk about what I feel is really one of the best, if not the best in class diagnostics to date. And that is the Pentacam AXL WAVE. And we're going to be focusing, no pun intended, on the full sequence displays for cataract and refractive surgery. So the Pentacam AXL WAVE, this is really the latest iteration in the ongoing evolution of Scheimpflug imaging technology with the Pentacam. And this elegant device is a workhorse. This is an all-in-one device for the corneal refractive surgeon, for keratoconus evaluation, for phakic IOL planning, for both refractive cataract and refractive lens replacement surgery. Can provide data for guidance on intraocular lens selection directly. And of course, serves as one of the most important tools in my institute for patient education. And this is all done with a single device. It also now allows for post-op assessment to see how did we do. Well, why the WAVE in the Pentacam? The Pentacam has, as you heard me mention, has gone through a number of iterations over the years. First, we had the high-resolution Scheimpflug, which allowed for high-resolution Scheimpflug imaging. Then we had the addition of biometry into the wavefront with the AXL. And then the latest entree into this diagnostic workhorse is the inclusion of aberrometry as well. And again, all in a single device. Well, what is unique about this beyond that? This has some distinguishing features in terms of the wavefront aberration assessment. Most importantly, and I'd like to emphasize that this not only measures corneal aberrations, and when I say corneal aberrations, this is true front and back assessment, corneal aberrations plus internal aberrations, and can separate these independently to give total eye aberrations. And we can actually see the representation of the image quality which each of these truly represented. So with the cornea, we have the Zernicke display, we have the internal visual performance display, truly looking at internal optics alone. And let me be clear, this excludes posterior corneal information, and then also gives us the total aberrometry display. Well, again, why is this unique? Well, it's unique for many reasons. This, first off, there's no glare used before and during aberrometry, and this allows for larger pupil diameter. As every corneal refractive surgeon knows, aberrometry is 100% pupil limited. So the more pupil we have to work with, that is, the larger the diameter, the more information we have and optical information we have to capture. You've already heard me drive home the fact early in our time together tonight that this provides a true calculation of the internal wavefront of the eye, of the wavefront path. That means that the posterior cornea is excluded from the internal wavefront. This is really one of the only devices that actually provides true internal wavefront data, separating true internal wavefront information from external wavefront information. To be more clear, this provides true calculation of the total corneal wavefront. It's not just anterior cornea, this is anterior and posterior cornea data. And why is that important? Because it allows us to truly understand, is this a lens issue or is this a corneal issue? Is this a patient who has corneal aberrations from prior refractive surgery? Or is this a patient who has stage 2 lens dysfunction with internal aberrations? And might we be better sort of looking at a lens-based procedure because of that? Again, one of the only devices that allows us to separate out true internal from external aberrations. Furthermore, this provides wonderful insights and prediction of post-op visual performance using spectacle correction. It's been shown to be highly repeatable, as we'll see tonight, and we are currently have a global normative data project for total eye aberrometry. So we have information for standard deviations that Pentacam and Oculus have become known for at a glance, putting in this into a single or a double standard deviation from the normative means. Well, ladies and gentlemen, let's take a view of the full sequence overview. This is the new dashboard that basically has everything the corneal refractive cataract surgeon would need at a single glance. And we're going to go through this in more detail. But before we do that, I want to kind of give you a sense of what the workflow looks like when you have all these devices in one. Well, first off, when we look at the full sequence overview, this provides pupil diameter, not only in scotopic, but also in mesopic conditions, keratometry, of course, but keratometry in sophisticated ways, and we'll look at that. And of course, chords. What do we mean by chords? This gives us information on centration, not only pre-op for planning, but also for post-operatively, how did we do? Provides our standard corneal maps that we're used to, and also the Bell and Ambrosio final Ds. Now, what about the tricky cases? What about the cases that, like the patient I had in my clinic today, who wasn't sure if they had had LASIK in one eye or the other? They couldn't remember, but they could have sworn it was one eye, but the topography showed it was the other, and they were very certain that wasn't the case. Well, we have information where this can elucidate some of these queries. What about Fuchs endothelial dystrophy or the guttata visually significant and causing light scatter and this sort of thing? It also allows for matching based on normative data which makes this very intuitive and easy to use, and provides something unique with corneal optical densitometry as well. You've heard me say already that this, in our practice, is the single most important diagnostic tool we have to educate patients. In our advanced ocular analysis, we take patients on a digital tour of their eye, and we show them the performance display, and this is visual performance. It's a new concept that we're really using in our daily conversations with our clients. We can check visual performance using spectacle correction as well, so we can really get an idea of what their thresholds are. And then in our planning for IOL selection, again, at a glance, we have the high-level aberrometry information. We can look at spherical aberrations. We look at additional corneal higher order aberrations. We can look at our cords for centration information, and also pupil diameters in different lighting conditions. Well, what about IOL power calculations? This has not only a biometer, but it has the most advanced IOL calculators as well, all internally and in a display that allows us to customize this to give instant outputs on our IOL planning, where we can select the IOL formulas, whether it's a spherical, they have toric formulas and beautiful post-refractive formulas as well, and allows us to select the IOL of choice, and we can print the IOL power calculations. So let's dig in here a little bit. Again, I'd like to reintroduce you to the new full sequence overview in the phakic eye. Well, we have a very intuitive dashboard display, really with everything at our fingertips. And let's take a little tour. First off, we have a toggle switch where you can very easily, without drop-down menus, toggle to the right and left eye. That can be very, very useful, not only for us, but also, of course, for your technicians as well. Now, we also have a very impressive refractometer as well. So this provides refractive information that can be indispensable and serve as an autorefractor for your staff, so they can go plug this instantly into your phoropter without having the need for an additional autorefracting device. Plus, it also gives you information at a glance on what we're working with. Plus, it provides refraction in day and night based on the different pupil diameters in scotopic and mesopic conditions. And that is very, very powerful. So we can see here's an example of somebody with night myopia and where the spherical equivalent jumps up by a diopter and a half at night when we double the pupil size. Very impressive information. Now, the keratometry, this is one of the many ways where the Pentacam and the high resolution aspects of shine fluid tomography really, really shine. And so when we look at this, we've got the SIMKs in the anterior cornea that we're all used to, with the mean, the astigmatism. But then we also have the total corneal refractive power at 3 millimeters. And this can be really useful for highly aberrated corneas, and also understanding perhaps some of the more critical areas of the effective optical zone. It shows us the differences in the SIMKs and also the total corneal refractive power. Think of this almost more as instead of a few data points, it really gives us more of a geographic power, which is very, very useful and very, very important. Now we have the corneal properties, so we can actually look at a glance and get a sense of, hey, did this patient have LASIK or not? Just like the patient I had in my clinic this week. And it makes a big difference because we need to make a determination on what IOLs we're going to select. Not only that, but what formulas are we going to run as well? Well, when we look at the back to front ratio here, that gives us information. Historically, the back to front ratio has been shown to be on average human cornea around 82%. And so that gives us a reference point to understand, might this patient had surgery or is there something going on? Of course, we have our corneal thickness, and then our chords and distances. Well, a number of years ago, myself and Daniel Chang published a term called chord mu, which was merely a clinical attempt to find a reference axis for clinically relevant centration purposes. And this was, we proposed that these are not angles such as angle kappa, angle alpha. This was not a line of sight, both of which are based on math constructs from the 1800s with nodal points and assumption of having pupils and irises. So we went and proposed a new, what we felt was more clinically relevant terminology, of which now is used in most diagnostic devices with chord mu. And not only that, we went on to describe a vector analysis method for where the decentration or centration would be. And the good folks at Oculus have now built this into their diagnostics. So it shows you, is this patient have a high chord mu, a low chord mu? Is that something that we need to pay attention to? And then, of course, the axial length has been indispensable in our clinic when I'm looking instantly to make some determination in presbyopic surgery. Would this patient be a suitable candidate for refractive lens replacement for dysfunctional lenses? Because what do we want to keep in mind are the risks of retinal detachment in high myopes. So the literature shows over 25.5, we need to start paying attention in the absence of a PVD. And sure enough, at a glance on the full sequence overview, we've got axial length. So I can make some determination on maybe this patient might be better suited for a phakic intraocular lens, or maybe even LASIK. Again, all at a glance. So very, very powerful, very high level, not having to jump through multiple menus or drop downs. And then, of course, we have retroillumination with the shine fluid and the axial sagittal curvature of the front, as well as the total corneal refractive power maps, all of which are so important when we're taking a patient on a tour of their eye. Now we can show them their visual performance in the cornea, the internal optics, and the total eye, and they can see right away this patient has internal aberrations, in which case we could really make a better case for recommending lens replacement. And then, of course, the cross section is the classic view in the shine fluid, where we can see the cortical spoking by cross section, and then it really hits home with our retroillumination. So it wraps it all up into a very intuitive discussion and conversation, and you've got everything you need at a glance. Well, how do we use this for screening? Well, again, here's an example of the patient I saw this week. Could have sworn they had LASIK in their left eye, bet their life on it, and they were positive it was eye that was set for reading, but when we look at it in the left eye, it was totally normal with normal corneal thickness. But when we look at the right, he had myopic LASIK, so it looks like somebody who was previously myopic, and they did myopic LASIK for distance in the right, the left eye for reading, but the patient was 100% certain that was the opposite. So when we look and draw our attention to things like the back to front ratio under corneal properties in the right, that kind of gives us a lot more information. That's starting to deviate from 82% of a normal back to front ratio. Clearly, we see a myopic ablative pattern with a thinner central cornea. And so we can, again, help reassure the patients, even though their records weren't available from the 1990s, that this patient had a myopic LASIK profile, and that's okay. What else can we look at? Well, spherical aberration. This patient has a decent amount of positive spherical aberration from a small optical zone and an old highly myopic LASIK. So again, it gives us further information to understand this, that the refraction of only minus 0.75 does not match with the axial length of over 26. So again, now we know that's somebody who probably was a -6, -7 diopter myope previously, and we can help reassure them that we can restore their vision through the appropriate means. And then, of course, we've got flat, thin corneas and a very low back to front ratio, as we mentioned. Well, we mentioned corneal densitometry. Now, that's sort of a new concept that can be very useful in certain clinical settings. This is just one example. And friends, what are we looking at here? Well, when we look at the bottom left scattergram, what we can see is light scatter in a normal distribution with higher signals of intensity in this ring. And that ring is being pointed out by a blue arrow on the right eye. And this is really neat because this goes on to show a scattergram and a cornea densitometry graph that can show hotter areas as though it was a analog to steeper keratometry being hotter. Here we have hotter areas for higher levels of reflectivity in corneal densitometry. And then we can actually map this across the profile in the cornea. So the top right, hot red with the blue arrow showing me there's high levels of density. Bottom corneal densitometry across the profile of the cornea. As we get out towards the periphery, we see a spike of densitometry at around 9.5 millimeters. Well, this is that same patient we just showed you. What might that be? Well, that's their LASIK flap in the right eye that they swore that they never had. And so there you see the periphery of the hyperreflectivity of the flap edge, and again, sort of seals the deal on something that should be pretty straightforward with your topography, but you got a patient in front of you swearing it was the opposite. This just helps you reassure them, and helps you be more efficient with your measurements. And moving on to the next part of the lecture, which is, well, now what do we do with our IOL power calculations in a post-myopic LASIK patient? Well, ladies and gentlemen, one of the most powerful things about the AXL wave is the ability for it to self-populate with what we feel is some of the highest yield corneal data that you can get on any diagnostic, and it feeds it directly into some of the most advanced and contemporary IOL calculators. And you have drop-down menus that show you and allow you to customize your preferences based on your practice patterns. So this is all automatically imported from your scan. And you can see you got everything you need for these post-refractive calculations without prior records. As you can see, K1 pre-refractive, K2 pre-refractive in the top right are not populated, but everything else is self-populated for you. And that is really, really useful and really, really exciting. So as we kind of dig into this a little bit more, and here we've got two at-a-glance calculators, the Hill-Puff and Chamas, and also the Barrett True K, and both very popular in different parts of the world. And what we can be real reassured, because when we're in our post-refractive tabs and we've got our lenses that we've selected for this particular patient with the history of post-myopic LASIK, as we've established based on all the information provided, this shows us with two independent calculators, this patient would do best if we're targeting plano with a 19 diopter lens implant. And that is really, really reassuring with a patient who's telling me they didn't even have LASIK in that eye. So let's look a little bit about what happens if we had put it in the other eye and took it to heart. They were 100% certain, and we ran post-myopic LASIK calculations on the eye that never had LASIK. Okay, well, we can rescan them, and we can't figure out why they ended up out of focus after surgery. We can not only do a check objective refraction, we can get a full sequence overview, check the Ks, check the color maps, and of course we get our front image post-op axis. And this is one of the really neat new features about this technology, and I'm excited to show you this. And another fabulous feature is you can rerun the IOL calculator in the pseudophakic status. So not only are we looking at the pseudophakic images and measuring these images, we use a toric, let's say, and we're trying to figure out, was that part of the etiology of the refractive surprise? Well, was this patient grossly decentered? Did they have a high cord mu? And did it matter? Well, it can definitely matter. And but how do we even know if this patient can do better? And more importantly, what should we do? What lens should we pick? Well, the Barrett RX is a very useful tool that it can be a little tough to find online to run these surprise calculations. And now we have this available in a diagnostic device to help us select the best option. Well, should we rotate the toric lens? Should we just place a piggyback? And if so, what should that lens power be? Or should we exchange the lens? But more importantly, what should we exchange it for? And this tells us all of this. Well, here's an example of a x-soft toric lens with a refractive surprise. And we can simply look at the post-op axis position. And if we look over to the right panel and ask it to measure the IOL position, it actually does a real-time overlay, not only looking at our cords relative to whatever reference axis we determine to determine centration, but also is our IOL on axis or not? So is it centrated? What direction is it decentrated? And is it on axis? So is part of the question a rotational issue or a centration issue? Very, very useful. And again, very few diagnostics allow for this kind of information. Well, we've got a very nice body of evidence that's rapidly expanding, and a lot of this is from Rohit Shetty's group in India, where they had some of our early access to this technology. We were very fortunate to introduce this to the United States in our center. And we've also participated in a number of the normative data collections and have found similar results to a lot of what Rohit's group has shown. But basically that these are repeatable with highly aberrated corneas, difficult to capture corneas with aberrometry in normal and keratoconics and cross-linking groups, looking at other aspects of cross-linking patients with corneal densitometry, trying to understand, are we seeing some hyperreflectivity that shows that we've had treatment? Other things like looking at Fuchs endothelial dystrophy, and do we see hyperreflectivity that might warrant an intervention? And we've got objective feedback on that that's affecting the total eye wavefronts and separating out internal corneal performance from the perhaps a cataractus lens, where we can see really what's the contribution. We've never really been able to do that. So very, very powerful. And as a result, the Pentacam AXL WAVE really, in my mind, represents the next generation in advanced hybrid diagnostic technologies. The new full sequence overview provides a comprehensive cataract and refractive screen at a glance, and we've gone through this carefully tonight and really done a very intuitive walkthrough of which you can just visualize how intuitive it would be when you're sitting with your clients, helping educate them on what the best decisions are. There are some unique aberrometry features, such as true separation of internal and external aberrations that we do not see anywhere else in the marketplace. And that, in my mind, is one of the primary distinguishing features of this technology. And when we combine the anatomic imaging, whether it's in cross-section from Scheimpflug densitometry or the on-face retroillumination views with advanced biometry, surgical planning, access to the IOL calculations, post-surgical planning and guidance, this really provides a powerful all-in-one device for the comprehensive cataract and refractive surgeon. So ladies and gentlemen, I just want to take this opportunity to thank you again for spending your valuable time with us tonight for education's sake. If you can take away 3 learning points from our time together tonight, then I feel it was worth your time. And I'm happy to entertain questions, and I'm always available to you on behalf of Oculus. And we're just really excited to get the opportunity to speak to you about this technology tonight. So thank you so much.
Well, George, thank you very much. A lot of information there, a lot to digest. And we've got some very good questions that have come in tonight also. And the first question I'm going to ask you is a question that we get in our clinical applications team all the time. It's regarding planning for toric IOLs. And could you comment a little bit about, let's start off with axis selection. And if you look at the K readings, and then you look at the total corneal refractive power K readings, and there's a significant difference, how do you approach that when choosing the axis for your toric IOL?
So the question is, how do we interpret, now that we have access to posterior corneal information and total corneal information, how does that change or affect our decision-making in toric IOL planning? The game has changed in corneal and refractive surgery, and we're all owed a loaded debt to Doug Koch and Li Wang and their group for introducing us to the concepts of posterior corneal astigmatism. So we have to think of the cornea as 2 different corneas, the front and the back. And you simply cannot treat astigmatism by only treating the front cornea. It just does not work because you're only treating part of it, or you're over treating part of it. And so it's imperative that we have ways to directly measure the posterior cornea and the anterior cornea, and then feed this information into calculators that are designed for this. Prior to that, we did all this with normative data based on Doug's work and nomograms without direct measurements. And it's interesting, most of those predictive patterns have held true even in the absence of direct measurements. But what we found is that they were falling a little bit short, and that necessitated the need for measuring total cornea power directly. So, for example, the majority of patients have posterior corneal width the rule astigmatism. Not all, but the vast majority. And the posterior cornea acts like a minus lens. Therefore, it contributes against the rule astigmatism. And we know that most patients through life move from with rule anterior cornea to against the rule anterior cornea due probably to a lifetime of blinking and corneal reformation and shape change. So as we move through life, we have a shift of compounded posterior corneal against the rule astigmatism. That is to say, the posterior cornea doesn't change through life. So your with rule astigmatism as a minus lens creates effective posterior cornea. Plus, now later in life, when we're usually doing lens surgery, we have against the rule anterior corneal astigmatism. So now you got double against the rule astigmatism. So the simple way to think about this is you treat against the rule astigmatism twice as aggressively as you do with the rule. And in fact, if you want to really stretch your thinking, now that we have access to aberrometry with this device, we've gone so far as to treat against the rule astigmatism with 0 anterior corneal astigmatism. Why would you do that? If you don't have any anterior corneal astigmatism, you have nothing to counteract the posterior corneal against the rule astigmatism. And as a result, you manifest posterior corneal astigmatism. So we actually are treating against the rule astigmatism in somebody without anterior corneal astigmatism. And I know that's a weird thought and might be a little bit of a head scratcher, but it drives the point home. And the opposite is true for with rule astigmatism. You treat half as aggressively. Your goal is to leave about 0.3 diopters of with rule astigmatism to counteract the posterior cornea's contribution. So we use the total corneal power. We feed that into our nomograms and our toric calculators. And on average, if somebody has a total cornea of, and let's say if somebody has just an anterior corneal astigmatism of 0.65 diopters or more against the rule, we're going to use a toric. And then you can simply double that if you're looking at the anterior cornea alone for with the rule. If somebody has about 1.5 or more with the rule, then we're going to use a toric. And then the guesswork comes out of it based off of normative data when we do the real-time measurement. So it's an important question. It's a lot to unpack, but the other point of this is these same tenets hold true for corneal refractive surgery, including limbal relaxing incisions, of which no nomograms are really optimized for. So in our personal LRI nomograms, these are optimized for posterior corneal astigmatism. So we are just really count on the ability to measure this real time.
It is interesting. Before we looked at posterior corneal astigmatism and didn't really account for it, we really didn't understand why we get so many surprises. And now it really makes a lot of sense when we see flipping these axes and things when we ignore the data on the back of the cornea. Really is so important. Our next question, George, is regarding multifocal IOL consideration and chord mu and chord alpha. Currently, the Pentacam doesn't have cutoffs in there for those two values for chord mu and chord alpha. And in the literature, historically, there's been some talk about various cutoffs. The literature doesn't really agree on what cutoff should be used. And I think with the advent of a lot of the newer multifocals, probably some of the literature is a little bit out of date also on what to use for some of the newer EDOF lenses and some of the trifocals. But can you just comment a little bit about when you look at chord mu or chord alpha, and if you're considering a multifocal IOL, what numbers make you uncomfortable?
Yeah, absolutely. It's an important topic, and again, there's a lot to unpack on these simple questions. First off it's understanding what chord mu is, and this is essentially the description of real-time ray tracing, and our original paper was the subject fixated coaxially sighted corneal light reflex, and all those elements need to be present for us to measure and determine chord mu. But you can do that under an operating microscope. You can do that under a diagnostic device, as long as those elements are satisfied. So notice we didn't make any reference in that definition to the nodal point or pupil centration. I mean, if somebody doesn't have an iris, well, gosh, does that mean that they don't centrate and don't have a reference axis? Well, of course they do. And likewise, and remember, that's part of the definition of most of these historic terms. And likewise, the nodal point's just math, so that's not a human body. Served us well for a couple hundred years, but that's not a clinically relevant description. So then, now that we understand what chord mu is based on our original description, then does it matter? Well, ladies and gentlemen, we know it matters. We know centration matters, and this was based off of our corneal inlay work a long time ago, where we would, which was really the basis for this discovery and also the basis of the research. When we had people that were decentrated with corneal inlays, they'd have loss of acuity. And when we centrate them, they would have instantaneous recovery of acuity. So it definitely makes a difference. And we've seen this with multifocal lenses on occasion, but rare, but it occurs. And it occurs in many different settings as well. But the question is, does it matter? Well, it's hard. It was very difficult. We couldn't show a signal in our research that it made a difference on visual acuity. But it was ICOMed's group and others that published in the Blue Journal that centration does make a difference for internal aberrations such as coma. And that makes perfect sense, makes all the sense in the world, because a decentered aberration is essentially gives you coma. It's like decentered spherical aberration. That's what coma is. And these are internal measurements. So we do think it matters, and we definitely seen resolution of symptoms and improved acuities with recentrating presbyopia correcting IOLs. So the next part of this is, well, should there be a cutoff to stay in the safe zone? Our philosophy on this has always differed, but our tolerances differ a little bit too. So we are glad that Pentacam does not have cutoffs available in there, because we personally don't think it matters. And why? Well, think about your patient with the highest degrees of cord mu. What would they be? I'll give you 3 seconds to spout out an answer. Well, it's your high hyperopes. Why is that? Well, in the hyperopic eye, eyes are short, they're compact, and when that's the case, the fovea is swung out and decentered temporally. So when you ray trace, that means that you get essentially a pseudo strabismus and a pseudo XT pattern, because you have a mismatch of the corneal light reflex relative to the entrance pupil. And again, who are usually your happiest patients with IOLs in general and multifocal patients? It's your hyperopes, right? So we use diffractive presbyopic technology a lot and have for a long time. Our practice is known for it. And we are a presbyopia surgery correcting practice. It's one of the pillars of our practice. So we have, for our career, have used diffractive IOL technologies in extreme cord mu patients, but we take an extra step and we centrate intraoperatively for these patients based on the subject fixated, coaxially sighted corneal light reflex to account for large degrees of cord mu, where and in very large degrees, we may split the difference in terms of where we center the lens. So we're paying attention to this. So again, these are simple questions with not simple answers that we personally do not feel that it should be an exclusion criteria. We think you would be excluding way too many patients that would do beautifully. But we have seen the occasion, and perhaps not in a cord mu patient, but other factors such as large capsules, of which we've also described in the American Journal of Ophthalmology, the variance in capsule diameter, and some of the lesser known aspects of effective lens position based on intraoperative imaging with OCT. So we think there's a lot more to it than just cord mu in terms of trying to predict where the lens should be situated postoperatively.
Excellent. I have one more question for you, and I want to go back to something you said in the very beginning of your presentation, and it's about the journey through the eye that you take patients through. And so someone's asking the question about how do you use the Pentacam for patient education? And I've been to your clinic and I've seen what you've done and what you do with every patient and the way you use an iPad. And could you just walk us through exactly what you do to the best you can, how you use the Pentacam as a patient education tool and why it's important?
Sure. We take patients on a digital tour of their eye, and this is something that I credit Dan Dury with kind of creating this concept of the advanced vision analysis or advanced ocular analysis. And so I did my training with Dan. He's my mentor, and so we learned that during my fellowship, and we designed like many people have done a digital ocular analysis area that's part of the client experience. So it's a large center of all the diagnostic devices, and patients have a standard operating procedure based on what they were referred for surgery. So they'll go on a different track and a different sequence of digital devices. All this gets imported in through our electronic medical record and straight into my iPad. And the beautiful thing about the Pentacam AXL is it provides really just about all the information we need, short of the macular OCT, which we use OCT for. And it allows us to take patients on a diagnostic digital tour of their eye using client-centric terminology. And again, it's part of we're an experiential clinic and an experiential institute, and it's part of the experience. But interestingly, we're not using scientific terms, we're using client-centric terminology in ways that is very, very easy, intuitive for patients to understand. So we'll start by showing them the Scheimpflug tomography. We'll explain that the eye is like a camera. To take a good picture, we have to focus the camera and the lens needs to be clear and the film needs to work. So I'll show them their tomography, and I won't use the word astigmatism. I'll just show them that they are out of focus. Their camera's out of focus, and that's one of the things that we're here to fix. Then we show them their Scheimpflug densitometry, the cross-section of their eye. We don't say any of that. We just say, we're gonna take you on a deeper look here, and look, there's more to the story. Your lens, or the lens of the camera here is also cloudy. So not only do we have a focus issue, we've got a clarity issue as well. Both are affecting your vision, and we want to fix that. And we're showing them the Scheimpflug image of their crystalline lens, whether we're describing and teaching them about the lens dysfunction that they have in presbyopia or cataracts. And then we go on to describe the ways that we can fix both of these things and also restore the reading vision at the same time. So in a few moments, and this is streamlined down to a 5 to 7 minute encounter, we have done it in a way that nobody's rushed, everybody's comfortable and enjoying it in a way that's very easy for them to understand. And we've helped them understand that we're going to fix their focus, fix their cloudiness, and restore their reading vision for the rest of their life. And it's just been wonderful, and patients love it, and they appreciate it too.
And George, I would say, talking with your patients after their consultations, and I think the lack of the confusing technical jargon that we all use sometimes that can only confuse patients, I think that your patients are amongst the best informed, and they feel empowered to make good decisions about what surgeries are best for them. So I want to thank you tonight. This was really informative, great information. And I want to thank everyone for joining us tonight. And this recording will be available in approximately a week in case anyone likes to rewatch it. And again, I wish everyone a wonderful evening, and thanks for joining us. And George, thank you so much.
Thank you, Bill, and thank you all again for joining us tonight. We hope you'll learn a few things and appreciate the opportunity.
Have a great evening, everyone. Thank you.